I'm joined today by Dr. Cathy Winfield, who's the Senior Responsible Officer for Primary Care at North West London ICB. Welcome, Cathy.
Hello, Linda. Thank you.
And thank you for sharing your time with us today to talk about the role of ICBs in the NHS. Perhaps you could describe the role of an ICB and where it sits within the infrastructure.
Yeah, so the role of integrated care systems is to bring together all the partners in the public sector landscape to improve the health outcomes of populations broadly. So that would involve working with all of those organisations that provide healthcare services. That's from GP practices through to large acute trusts and partners in the local authorities. That would include public health functions, children's services, adult social care, and all of those functions that contribute to the health and well-being of communities. So very much about determining strategies at a macro level. They cover large populations, and then driving that integration on the ground in neighbourhoods for local service delivery that wrap around residents and communities within their geography.
So how many ICBs are there?
There are 42 in the country.
42. Okay. And so they're based on distinct geographical areas?
Yes. So you will have the NHS England, who are running the NHS, and they get a mandate from the Department of Health every year to sets out the objectives and requirements from NHS England. So NHS England develop policy, strategy, and allocate funds to ICBs, largely based on their population and the characteristics of those populations, deprivation and age and demographics. So we then get our budget, and then the job of the ICSs is to develop a local strategy, the local plans for implementing those national strategies, and deliver on the ground and marry that bottom-up understanding of communities with those national requirements. So if you take things like recovering elective surgery after the COVID pandemic, there'll be that is a national priority. There'll be national targets set to recover that activity, but locally on the ground, the ICB will be working with provider organisations, encouraging them to work together to provide mutual aid, driving transformation, driving efficiency, driving theatre utilisation, and so on and so forth, driving review of waiting lists and looking at alternatives for some patients as a planned programme across their geography.
So how does that fit with primary care networks and general practices? Because I think sometimes people get a bit confused as to how they all fit together.
Yes, I mean, it is a bit like a Russian doll. That's how I describe it. So if you take what most people will, when they're engaging with the health service, they'll be engaging with their local GP practice most of the time. And around GP practices, we've also got pharmacists, dentists, optometrists, so all of those primary care contractors. That will be most people's experience of the NHS. Those GP practices work together in groups of practices, usually covering a neighbourhood of around about 50,000 in primary care networks. But the next iteration on from that is for us to think not just about those GP practices being networked, but all the services that are around them coming together into integrated teams within neighbourhoods, so integrated neighbourhood teams. So you go practice, primary care network, integrated neighbourhood team. And the integrated neighbourhood teams would include the wraparound community services like district nursing or health visiting or community rapid response, twilight nursing, some of the nurse specialists like tissue viability or diabetes, so that within a neighbourhood you'd have primary care, but also the wraparound community services. You might well have mental health services wrapped around as well, and then obviously the social care response, and reaching out into the voluntary sector, because there's usually a web of voluntary sector organisations in any neighbourhood, and it's how do those integrated neighbourhood teams really work together. And the point of that is to stop patients feeling that they get pinged from one service to another, but nobody really picks up the entirety of their need and sort of works it out and helps them manage their way through the system. And we hear that a lot, that patients get referred to a service, that service says that's not me, or you don't meet my referral criteria, they go back to the GP tries something else, and people ricochet around the system. And it's often people with complex and overlapping needs that applies to. So this is about saying, as a team, we will get together, we will look at the needs of that individual, we will hear what their thoughts are about their care, and we will work together across those boundaries to deliver in a more integrated and seamless way. So it's about better meeting the needs of patients, but also about a more efficient way of working, and hopefully the staff a more helpful and joyful way of working as well, because the job on the ground has got to be something that people want to do.
Yes, and it's interesting, isn't it? A lot of times I get asked, what is the difference between a CCG and an ICS ICB?
I think the key difference is that it's getting away from what might have been quite a transactional approach in some systems. So commissioners sitting on this side of the fence, commissioning activity from a provider. I certainly learnt in my career as a commissioner that generally or frequently the expertise on how to redesign or how to do something better will sit with the provider, because they're doing that every day. So it's better to say, as a commissioner, so if I take my own experience as what was an accountable officer in a CCG, we were looking at our data and we could see that for diabetes, we were in that quadrant of high spend and poor outcomes. Well, you don't want to be there. So the question then becomes, how do we get out of that? How do we get into that high outcomes and lower spend quadrant? And that conversation happened across the system with a range of people, from organisations like Diabetes UK, patient groups, community providers, GPs in general practice, and also secondary care, where most of those patients had historically been cared for. And in fact, the programme was chaired by a patient. And what we ended up doing was redesigning the pathway so that we ended up to get collectively agreeing that what we needed was a much more of a community-based service led by a community diabetologist, a consultant for the community, with a team of nurse specialists, and that between them they would support clusters of practices, and that we would improve the education and training of healthcare professionals, we would provide patient education and training, we would develop an electronic care plan that patients and professionals could both contribute to, and we would change our style of working with patients. They would become experts in their own condition. So all of those changes were kind of decided collectively. And then as the commissioner, we could just go, well, if that's what we're doing, this is how we're going to allocate resource along that pathway. Some needs to go into training, some needs to go into primary care, some needs to go into the secondary care services. And it becomes much clearer then how you commission. But it wasn't us sort of sitting in a darkened room dreaming stuff up that the providers or the clinicians were going to think that just doesn't make sense on the ground. So it was that kind of collective way of working. And for me, that meant, to a degree, ceding some control and having faith in the collective to do a better job than we would have done as an isolated entity. And that hypothesis was proved on a number of occasions. So it was definitely the right way to go. And that's really what ICS is there to do, to convene the system and get the system to work collectively in a different way. Of course, we still need to have contracts and allocate resource, but to do that based on a shared understanding of the needs.
That's brilliant. So thank you so much for taking the time to talk to us today. Dr. Cathy Winfield, thank you.
Thank you.